Hi, once again, good day to one and all present here. I wish to express my immense gratitude and heartfelt thanks to the President, SEMI, members of the Executive Board and National Board SEMI, and the organizers for this fine opportunity. Thanks to the co-speaker and to the listeners. Once again, truly delighted to be part of this academic extravaganza. My name is Dr. Rajadurai, Head of the Department Emergency and Critical Care, Apollo KH Hospital. I am a National Secretary for Society for Emergency Medicine in India. Thank you. Today I am going to talk about some basics on initiation and modes of a ventilator, which is in a perspective slightly different from what we usually hear or talk. As usual, I'm going to keep this lecture and talk very crisp and try to convey a few salient points. First of all, is this topic important? Do an emergency physician need to know about mechanical ventilation, because we are going to use only ventilation for a very short while? Do you think we need to know in detail? The answer is clearly yes. We witnessed a relatively longer time of patients on mechanical ventilation in ER, that too with a very bad lungs during the second wave of pandemic. And so many examples I can quote, and this is one such example that our skill set and knowledge on mechanical ventilation further needs to be armored well. Yeah, I have a long objectives to talk on, of course, which includes the basics, bit of history, variables, etc. And the short objective would be to save lives. Yeah. These are all some of the references from reputed journals and articles which I used to prepare this PPT, and most of the slides will have the reference material too at the end of this content. Okay, a little bit of history with regards to mechanical ventilation. I think every time a pandemic is creating the need for innovation and discoveries in healthcare, and yes, the negative pressure, as you can see in the slide, negative pressure ventilation dates back as early as 1950s during the time of polio as a crisis to humankind. From 1950s till today, positive pressure ventilation and of course ventilators are undergoing substantial development and innovation. Which is all can be seen from these slides. Right. It's time for some basic definitions. What is a mechanical breath? Which is a basic unit of mechanical ventilation, a breath released through a ventilator system. What is mechanical ventilation? A series of mechanical breaths. Mechanical breath types depending on the combination of variables. Right. Which mode to choose? I have seen so many of us will approach with a prefixed ventilator mode before we would have seen the patient. As it has been clearly mentioned, mode is just one of the many important issues during mechanical ventilation. Ideally, a mode to be decided based on the patient. We need to consider the primary disease, the pulmonary function, and other complication, lung dynamics of a patient. Of course, us, the clinician, what expertise we have, what resources we have, and what support system we have. And the third one should be the machine. So patient, clinician, and the machine should be the three important factors for you to decide a mode. It's not just having a prefixed mode in our mind and approaching the patient with that mode. So it should be a dynamic process, and we need to consider mode ideally on these situations. So initiation of mechanical ventilation. We need to confirm the need for mechanical ventilation first, which is the indication, and we need to confirm whether the patient requires invasive or non-invasive ventilation, and of course other things like connection, circuit, self-test, mode, variables, alarms, and we need to connect to the patients, and we need to reassess. As I used to say to my postgraduates, a mechanical ventilation, it has to be a dynamic process. You cannot connect or commence a mode of mechanical ventilation with specific settings during a beginning of your shift and leave the patient till the end of the shift. You need to constantly keep reassessing, and as and when it is required, we need to do a subtle change or a massive change according to the variables and hemodynamics we have monitored. Right. So indication. Many textbooks have given a wide range of indication for mechanical ventilation, and in short, all would fit in either of the following, which is mentioned in this slide. Patient not breathing. Second thing, patient breathing, but definitely not enough. Patient breathing adequately, but the gases or your pulse ox is showing otherwise. Patient having increased work of breathing with potential exhaustion and respiratory arrest. Patient requiring intubation and mechanical ventilation because of airway protection. Of course, we need to check connections and circuits. As I always used to say, right hose in the right place. There is something called as pin index system, which literally does not allow the wrong hose to the wrong pipeline, which means we cannot connect oxygen to the nitrous or nitrous to the oxygen or vacuum or suction to oxygen and vice versa. But with force, with modifiables, mistakes do happen even with these foolproof methods. So always we need to be vigilant, and vigilance have to be dynamic. We need to do a self-test. Of course, intubating a patient or stabilizing an airway are always adrenaline moments. We don't have much time. But once that has been done, after you stabilize a patient, connecting to the ventilator, you can wait till the machine does the self-test. So always allow your machine to perform full self-test whenever it is appropriate. Select mode, as I told you, depends on the patient status, your comfort, and the availability, that is the machines. So these are all the few basic principles you need to consider before you select the settings for your patient in your ventilator. Whenever there is a problem with oxygenation, always adjust FiO2 and PEEP. When there is a problem with CO2, adjust your tidal volume and respiratory rate. Make sure you maintain spontaneous activity. Always optimize alveolar recruitment. Lung protective strategy should be there right from the start of ventilation. Whether you deal with a good lung or a bad lung, we need to consider lung protective strategies at all times of your mechanical ventilation. And you need to see that there is no disinclinity between a patient and the ventilator. Variables. Setting up the variables. There are three types of variables: control, phase, and baseline variables. So variable determines the type of mechanical breath. For example, all these things are phase variables, which in the phase variables includes triggering, cycling, controlling, targeting, and baseline. Trigger defines when your inspiration should begin. Cycling is when the inspiration should end. Control is the delivery of inspiratory gas. Target, of course, as the name suggests, size of the mechanical breath, and baseline is the pressure, baseline pressure. So these are all the control variables: the volume, flow, and the pressure. The phase variables, as I was mentioning in the other slide. How do you set the variables? Excuse me for that technical glitch. Yes, coming back to this presentation. For setting up the variable, we need to consider all these things. All these things I have mentioned in the previous slide of mine too. So a mode, you need to select the mode. Either it can be a complete support or a partial support. Rate, titrate according to PaCO2. Tidal volume, ideally it should be 6 ml per kg with oxygen. And the flow rate and pattern, 4 to 8 times of the minute volume, square or decelerating. Inspiratory to expiratory ratio, ideally 1:2. FiO2 based on the patient's saturation and the gases. PEEP titrate to PaO2, and sensitivity adjust accordingly. Okay, we need to set the alarms before we connect the patient or before we commence mechanical ventilation. There are fixed alarms and there are other alarms you need to take into consideration. Once we connect the patient, as I told, we cannot leave the patient and go on to other work. We need to constantly monitor and reassess. So apart from the hemodynamic monitoring, which includes heart rate, saturation, blood pressure, PCO2, we need to monitor certain important things like volume, pressure, weights, patient comfort and dysynchrony, if any, to assess, and we need to change the settings, adjust the settings and change the mode accordingly. So the choice of mode. So this is a take-home message. No mode is superior to another. In patients with ARDS, there is a ARDS net study which have used ACMV, which have used PCV also. PCV improves oxygenation and definitely not mortality. We don't prefer SAMV in our ICUs. Like many intensivists, we also don't prefer SAMV because it is going to cause muscle damage and recovery is going to be very, very delayed. So patient going to be on mechanical ventilation for a longer time, when we use SAMV, even for a mode for weaning. The number of days he's going to be on ventilator is going to be more. Number of days he's going to be on ICU is going to be more, and the complications are more. We have very good studies and time tested that SAMV we don't use in our ICUs. Any other mode doesn't mean it is superior to another, as I was mentioning. We can use other modes. So classification of modes depends on the type of support and the degree of support. Type of support, it can be either volume, pressure or dual. Degree of support, it can be partial, complete or both. So this is just an animation which make you understand what is a spontaneous, what is a controlled, and what are the other modes which are in between. Spontaneous, the rate is by the patient, power is by the patient. Control, the rate is by the machine and the power is by the machine. And we have assisted mode, which has got the patient as a rate and the power is by the patient as well as by the machine. And we have another mode which is assist control mode, which the minimum rate is by the machine and the additional rate by the patient, and the power is by the machine. So far we have spoken about a little bit of history with regards to mechanical ventilation, the importance of emergency physician knowing what is mechanical ventilation and what have to be done, which mode have to be selected. Few modes we have discussed, and the variables we have discussed. 5 important settings we have discussed before you connect the patient to the mechanical ventilator. Good luck with your mechanical ventilation. We'll be keep talking. Thank you very much.